Hi, everybody. Like I said, I don't know if everyone knows me. My name is Carolyn. I am the nurse coordinator, advanced practice nurse of pulmonary hypertension here in Ottawa. And I have the pleasure this evening of speaking to you about PH-101. I think that one of the things I was hoping was just to find out a little bit about how long it's been since diagnosis, if I can. And the reason being, I do notice that there's a couple of slides in the presentation. I don't want them to be too overwhelming, so I will make sure that I explain them as best I can. I don't know if you've all seen some of these images, so I will start. Been a nurse coordinator since 2007, so hopefully I can do some justice to this presentation this evening. And we'll look forward to seeing anyone who is coming to Ottawa in a few days. We'll look forward to seeing you when you get here. So the first slide here is, let's see here, I can try to advance the slide. I'll just do that. This is very common. This is a great slide. Sometimes what sounds like a horse could be a zebra. Pulmonary hypertension has symptoms of basically mimicking things like chronic fatigue, COPD, asthma, even obesity and anxiety. How obesity? Well, sometimes when you're moving around, if you're carrying an awful lot of extra weight, your body is now carrying around weight, which would make you very short of breath and tired. So these are the more common things for people who are short of breath and very tired. And so, basically what happens is doctors will take a look at the more common thing to diagnose a patient with. That's what you should do as a physician. You should look at, let's rule out the most, common things. So they may do some pulmonary function testing and or talk to you about diet and exercise, things like that. And if everything is coming out normal, certainly then we have to start thinking of the less common things. And what we've done here at PHA Canada, I used to be on the board at one time, and what we are trying to do is make sure that we help physicians understand the simple test that it takes to do when you have someone who has shortness of breath or fatigue out of proportion to what they should have. And hopefully we're doing a pretty good job at that. That is a global thing people are trying to do. It's not just here in Canada, it's not just in the United States, it's globally. We're just really trying to make sure that we don't miss this, because obviously, as you're all aware, it's a progressive disease. So the sooner we diagnose, certainly the better. So part one for the presentation this evening is the basics of pulmonary hypertension. And the basics include that pulmonary hypertension is a lung disease. It's a blood vessel disease. It's characterized by increased pressures in the pulmonary arteries. What does that mean? That means the right side of the heart has to generate a huge pressure to get blood into the lungs to get oxygen where it should be passively going into the lungs, because it doesn't have to go very far. Should take no pressure at all, like 30 millimeters of mercury systolic is about as much as it should take. So when it's higher, we have to try and figure out why. Now, pulmonary hypertension, PH, is an umbrella term. So that's pulmonary hypertension, meaning pulmonary arteries, pulmonary veins. And when the heart has to generate high pressures to get blood into the lungs, we start looking at all the things that it could be. PAH is pulmonary arterial hypertension, which most of you this evening have or a family member has. And that is a progressive disease. So that one is a disease of the blood vessels. So the inside of the blood vessel gets diseased and narrowed. And because it's progressive, patients will get worse over time. So we certainly want to make sure that diagnosis happens as soon as possible so that patients can get on medications, which we'll talk about a little later, and what they do and how they help. All right, so basically the thing we want to do is is get you on medication to slow the progression of the disease, but also improve your quality of life so that you feel a lot better and improve your, longevity. This is a picture that I just want to make sure I do it justice. So this is the circulatory system. I think what I'd like to just impress upon you at first is that it's a circuit. And so blood goes through the heart and lungs 4 to 6 liters every minute. And so that happens constantly as we're sitting here, and in a minute, you're going to have 4 to 6 liters of blood pumping through your body. And it is the blue part of the heart there. That is your right ventricle, the bottom one. Number 1 is the ventricle. When you have pulmonary arterial hypertension, the blood, the number 1 in the blue has to go push blood into number 2, and that is now the pulmonary arteries, and it's breaking off. And it has to go into all those tiny little vessels there where you see the 2 lungs on number 3. Those are where the oxygen and carbon dioxide exchange at the level of the alveoli. So the blood then therefore comes back to the red side, number 4 and 5, and then it gets pumped to the body. Happens constantly. And it should be such a low pressure system, as you can tell from the right side of the heart, number 1 into number 2 into the lungs. It really shouldn't be much effort. But if you were to take that number 2, those 2 blue vessels, those 2 pulmonary arteries branching off, if you were to narrow those, like anything, if you're pumping volume into something that's narrowed now, it's going to take a lot more pressure to get blood in there. So this is where, and this is good information actually to tell you that we get a lot of information from our right heart catheterization from this stuff right here, because we can tell the blood flow through your body, whether or not that's accurate, whether your cardiac output is 4 to 6 liters a minute or not. So we get a lot of good information. An echocardiogram is great, but it's not as comprehensive as a right heart catheterization that gives us some good information. So what is happening when I said those vessels, when they start narrowing and the heart has to generate a higher pressure? So if you look to the left, and that lung there with the blood vessels all throughout the lung, all those blood vessels are affected by the disease inside the vessel. And if you look to the left, that first one that says blood vessel and blood, it's nice and open. So you have a low pressure that has to just go through. It's low. To the right, you have affected blood vessels. And if you look and see how reduced the blood flow can get in late disease to the very right, you can see that that disease has really taken over the inside of the blood vessel, and it's very, very hard for the heart to generate a pressure high enough. So you're going to see pressures 40, 50, 60, 70. And that's when the heart begins to have a tough time keeping up with the demands of, trying to get blood in there. So this is the disease that is where the medications are zoning in to try and slow that progression right down. It won't cure it, but if we slow the disease enough, we can have you feel a lot better, and we can improve your quality of life, and we can improve your longevity. Yes.
Sorry, Carolyn, my apologies. We have a little bit of a technical glitch, and I because you are the host right now, could I ask you to go to chat?
Yes.
And I've turned on webinar chat. If you open up the chat function, I've turned it on so it says that it's open to everyone, but apparently it's not. Let's try this again.
Okay. So
I've just typed in to everyone. Is the chat open now? Can you see that, Carolyn?
I can see it. Yeah, I can see it. Yeah.
Okay. I don't know.
It says PHA Canada to everyone now.
Yeah. And I not yet, so still not available. Okay,
that's strange because it does say to everyone.
I know. So if you could, I don't want to interrupt, and I apologize to everyone for this malfunction. I think You may need to email me, which is fine. I will answer those. But Carolyn, if we can try just one thing, if you could just click on chat and open it with that arrow, and you'll see you should be able to click on 2, and if it says everyone.
It says 2 hosts and panelists, that?
Yeah, but if you click on the arrow there, you have a choice. It says hosts and panelists, and then it says everyone underneath that.
PH Canada. So no, okay, no. It's actually just for me. It's for me to do. It's basically saying who I want to send it to.
But if you can't open that menu where it says.
I don't see that.
Where
I'm seeing under questions and answers, Beth.
You're under question and answer. I'm under chat.
Oh yeah, I was under chat first, but I don't have anything. So under chat, what I see is that you've sent a couple of messages, and then underneath it says who can see your messages. Two, and then I have hosts and panelists. Then I have PH Canada. Then I have Liz. That's it. That's all I have.
Okay, you don't have everyone. Okay. You know what? If there are questions, I would suggest so that we can carry on with our conversation, at least for Liz. I'm very sorry for the problem here, but it looks like our Q&A function is working.
Yes, it is. Yeah.
So I'm going to suggest I will monitor the Q&A function, and we'll treat that like chat. So
sure.
I apologize, and Liz, please carry on. Or sorry, Carolyn.
Yeah. It's okay. All right. So for symptoms, I don't really have to probably go over this with everyone. Dyspnea, it's huge. I mean, that's usually what you're most bothered by, or fatigue, or both. Exercise intolerance. So you for sure feel that, you might feel very good, like I can get up and do a whole lot right now, and then you peter out very quickly. If your right side of your heart's really having a tough time pumping blood into the lungs, it sometimes dilates. It sometimes gets a little larger, and therefore you're going to notice that you're going to have signs of heart failure because of that, which is the edema, the swelling, the fluid retention in the legs, feet, ankles, sometimes even your abdomen, because this is, certainly also right side heart failure can have a bloated abdomen. Chest pain, which is not the coronary artery disease type chest pain, but when the heart's under strain, that type of pain is very similar to coronary artery disease or angina. Cyanosis, the bluish skin, lips, and syncope is, or pre-syncope. So syncope is fainting, pre-syncope is I feel like I'm going to faint. It's why your doctor always asks you. We certainly want to make sure that as you're getting up and moving around, that you're not feeling that you might pass out and have to sit down. If you are, these are things you really need to talk to your doctor about. And then clinical signs of the right-sided heart failure as well. So your doctor may take a look at your jugular venous pressure here to see if the vein is beating here versus here. You'll have your doctor will be able to do a lot of tests to see if there's also clinical signs of the right-sided heart failure. And I have to hit the next button here. Risk factors are gender, age, family history. So if you have, somebody in your family who's had pulmonary hypertension, that could be familial pulmonary hypertension. Associate conditions like scleroderma, rheumatoid arthritis, lupus, congenital heart disease, things like that. Pregnancy, altitude, if you're in the higher altitudes, there is the pulmonary vessels constrict, and you can end up getting pulmonary hypertension just from that, constriction. Obesity, pulmonary embolism, or, those chronic blood clots, and or drug use. So drug use meaning types of medications like that people use when they're trying to lose weight if they're obese. The fen from the 90s and different types of stimulant type drugs like that can cause pulmonary hypertension. So let's go over those types and causes. So the group one, this is the World Health Organization classification of pulmonary hypertension. And they put this together, I think, at the time that fen-phen came around and young women were getting pulmonary hypertension due to that diet drug, fen-phen, if anybody remembers that. And so the World Health Organization, decided it's time to get some experts together to classify pulmonary hypertension, put it into some groups with some treatment options so we can help people. So pulmonary hypertension, the first number one there is pulmonary arterial hypertension. And that is the blood vessel disease that we talked about. It can be idiopathic, meaning no known cause, connective tissue diseases, like I said, scleroderma, rheumatoid arthritis, lupus, or genetic. Group two is the pulmonary hypertension. It's also called pulmonary venous hypertension or pulmonary hypertension associated with left heart disease. So the left heart side of your heart there's something going on there. Either the valves are leaking, the heart is pumping very poorly, or there's a stenotic valve, tight valve, and you get backflow into the pulmonary veins, and that is considered pulmonary venous hypertension. So all the high pressures are coming from the pulmonary veins, not the pulmonary arteries. That's patients with heart that go to heart failure clinics. That's what this patient population. Lung disease is for people who are hypoxemic, low oxygen, due to things like the lung tissue problems, which are COPD, pulmonary fibrosis, sleep apnea. And so therefore somebody with sleep apnea who is hypoxemic throughout the night, low oxygen throughout the night, over time can have a very mild pulmonary hypertension that is quite reversible with CPAP. And so lung tissue problems that would cause low oxygen are group three. Those patients stay with respirologists usually. Then there is group four, which is the blood clots, the chronic thromboembolic pulmonary hypertension. And that is patients who have had a pulmonary embolism that just has not gone away. It's not, and it stays around. It's quite chronic. The body doesn't break up the clot like it's supposed to for whatever reason, and we try to sort that out. And they, end up with chronic clot, which is very thick and fibrous, and it blocks the blood vessel. So again, the right side of the heart is having a hard time pumping blood through those very thick clots. And so those patients, if possible, should have surgery to get those out. And then there's pulmonary hypertension caused by various other diseases like sarcoid, chronic renal failure, vasculitis. This is not a patient population that we would follow because there's no treatment options for them due to those diseases. So World Health Organization Group 1 pulmonary arterial hypertension is the main topic here, that and CTEPH. Pulmonary arterial hypertension, again, a disease of the blood vessel in which the blood is not able to go through the lungs easily. And it can lead to swelling, meaning enlargement, dilation of the heart. And over time, the heart can fail and you end up with heart failure. And the exact cause of pulmonary arterial hypertension still not quite well understood. Do we know some things? Yes, we know some of the pathways that cause it. So we have medications that work on those pathways, but we certainly would like to have a cure. So we are still studying this disease so we can eventually come up with a cure. That's what we all aim to do. And it's defined in the catheterization lab. So that's the right heart catheterization that goes in through the jugular vein, or, a vein in the leg or a vein in the arm. And the ultimate where they want to get to is inside the heart to measure those pressures. Exactly. The echocardiogram is just an estimate. But this going in is the exact measurement, and we're not talking systolic pressure like the echocardiogram would say. So your echocardiogram is estimating the systolic pressure, the top number. This is inside when they go in and measure, it's the mean. So it's not the systolic or diastolic, but the mean pressure. If that's greater than or equal to 25 millimeters of mercury, then we know somewhere in the pulmonary arteries and veins, that entire system has a high pressure somewhere. And this is why we have to do this test, because all the governments really want to make sure that a patient is not started on a medication for pulmonary arterial hypertension if they have pulmonary venous hypertension. If they have pulmonary venous hypertension and start on one of our medications, we can cause the patient to go into congestive heart failure. So they do what's called a wedge pressure, and that wedge pressure needs to be 15 millimeters of mercury or less. The reason being, if it's higher than 15 millimeters of mercury, if they blow up a balloon inside the pulmonary artery, when that catheter goes in, they have a little balloon at the end to blow it up. Now we're isolating all the left side of the heart pressures, only seeing that. We were not able to see what's going on in the pulmonary arteries. And so we go higher or lower than 15. What is it? If it's higher than 15, that patient has pulmonary venous hypertension. If it's less than 15, that patient has pulmonary arterial hypertension. That means all the pressures are coming from the pulmonary arteries. And then we can say we've diagnosed that patient with pulmonary arterial hypertension. So the causes. Idiopathic, we don't know. No known cause. Genetic is inheritable. So we know that there's been a gene, and patients can, if they want, we can certainly send patients to speak to a genetics counselor to discuss it. A lot of people ask about that. Should I have genetic testing done? And we can talk to you about that if that's an interest of yours. If you have idiopathic and we don't know why, we can certainly talk about genetic counseling. If it's related, though, to other conditions, then we know why. That we still may not know the cause, but we know now why you have it, because some of the connective tissue diseases put you at that point in time, if you have a connective tissue disease, at a higher risk for developing pulmonary hypertension than everybody else. Scleroderma lupus, also rheumatoid arthritis, congenital heart diseases, some of those, HIV infection, and portal hypertension or liver disease. So the group 2, which is the left-sided heart disease patients, those patients have something going on the left side of their heart. And the heart could be pumping poorly, valves could be leaking or stenotic, and it causes buildup of pressures. And this is the patient population that ends up going to the heart failure clinics. They don't come to in our clinics, and they're treated by heart failure cardiologists. Now, anybody that's in Ottawa knows that Dr. Lisa Melnichuk sees patients with group 1 pulmonary hypertension, and she follows patients with heart failure. So she takes care of both patient populations. So she's quite knowledgeable about both systems. And sometimes, we'll have some of the patients that stay in our clinic with some left heart disease. Group 3, associated with lung disease. So these patients are, like I said, hypoxemic, low oxygen state. And once we find out that this is why you have your high pressure in your lungs, because low oxygen state causes those pulmonary vessels to constrict. When that happens, the heart has a harder time pumping blood. So the constriction, the way to help that is oxygen. So really, these patients have to go back to their respirologist, and the bottom line is that they have to just keep their oxygen as the highest levels that we can in order to have those patients, do a little bit better. And then the final here is the group 4, which these patients do stay in the pulmonary hypertension clinics. They have clots that do not dissolve. The body has not gotten rid of it. And it leads to these very fibrous, thick clots that also lead to some scars in the arteries. And after a pulmonary embolism, this is not that much, up to 4% of those patients will develop chronic thromboembolic pulmonary hypertension within a couple of years. So a lot of the thrombosis clinics that deal with these patients are acutely aware of making sure that these patients, if they become short of breath, are monitored for developing pulmonary hypertension and then get sent to our clinic. The other associated diseases that can develop pulmonary hypertension are sarcoid, chronic renal failure, vasculitis, other associated diseases. They don't, they may be referred, but they never do stay in our clinic. So we'll go into the diagnosis, kind of how that goes about. How do we go about diagnosing a patient? So the very first test that's usually done, that gives the physician who ordered that test a clue that we might be dealing with pulmonary arterial hypertension. The echocardiogram, it's it's non-invasive, so it's just an ultrasound of the heart. And it's an estimate there where the echocardiographer sends images to the cardiologist, and the cardiologist reads it, and they can estimate the pulmonary pressure. Once they see that that's high, pretty much, if the left side of the heart looks like there's no problems, no valve problems, no pumping problems, and the left side of the heart looks rather normal, they may, there's the suggestion to send a patient to a pulmonary hypertension clinic. And at that point, we ordered further follow-up. And the further follow-up would be things like, let's get a chest x-ray, let's get an electrocardiogram, pulmonary function testing for sure. We want to see if there's any lung disease, blood tests to rule out any kind of HIV, connective tissue diseases. There might be some exercise tolerance tests, CAT scan of the lungs in order to look at the lung tissue itself, to see if there's any emphysema. If we put some dye in that CAT scan, we can see if there's any blood clots in the blood vessels. So if there's a CAT scan done with dye, you can see, and then compare it to what's called a VQ nuclear scan, which tells us if there's a mismatch between the blood flow and the breathing. So those tests are usually what we will begin to do. And when we think, okay, the lungs seem okay, the left side of the heart's obviously okay, and we may or may not have blood clots, it's strongly suggested at that time to do a right heart catheterization. It has to be done. We have to have that pressure on the left side of the heart to see what that is. And this is the diagnostic, the final diagnostic test. Sometimes we're a little shocked, right? We think the patient's clearly pulmonary arterial hypertension, but that test comes across and they have a little left-sided heart disease. And why could that be? Well, it could be that the heart's a little stiff, and that just doesn't always show up on the echocardiogram. And if the pressure is higher than 15, we really aren't sure. Even if we think the patient does have pulmonary arterial hypertension, but the left-sided pressure looks a little high, maybe they have a little stiff left ventricle, we have to really consider whether or not a patient would do better or not on our medication. So that's a conversation between the patient and the doctor at that point. So we're going to go into part 4, which is the treatment, and I believe there's a little video here. So I'm going to stop talking for a second for a little video.
A diagnosis of pulmonary hypertension, or PH, can come with important decisions to make. Your medical team is there to help you understand what's best for your situation. Here are the PH treatment options that exist in Canada. 2 types of PH are treated using therapies that specifically target PH: PAH, pulmonary arterial hypertension, and CTEPH, chronic thromboembolic pulmonary hypertension. The other 3 types of PH are managed by treating the underlying disease causing the increased blood pressure in the lungs. First, to treat PAH, there are 10 medications approved in Canada. PAH medications are based on 3 substances that are naturally produced by the body: endothelin, nitric oxide, and prostacyclin. These substances help keep the blood vessels in the lungs working properly, but are out of balance in someone with PAH. Each substance represents a potential pathway to treat PAH. Medications from different pathways are often used in combination to better open up the blood vessels in the lungs. PAH medications can be taken orally, as a pill, or delivered directly into the blood through special equipment. Unlike all other types of PH, CTEPH is the only type of PH that can potentially be cured through surgery. The standard procedure is referred to as PEA. PEA is a major surgery that clears clots and scar tissue from the blood vessels in the lungs. PEA surgery is not suitable for all patients, and some people will continue to have CTEPH even after surgery. Additional treatment options for these patients include both oral medication and a new procedure that helps to stretch the blood vessels and improve blood flow. pH-targeted treatments can help improve symptoms and slow down disease progression, but they are not a cure. When other treatment options fail, lung and sometimes heart transplantation may be considered. But transplantation is major surgery that can be difficult to recover from, and organ donors may be hard to find. No matter where your PH journey leads, you are not alone. There is an amazing, compassionate community standing behind you. You probably have more questions. You can get answers and find more useful PH resources at phacanada.ca/videos.
So, yeah, like the video said, there's no cure, but we certainly can start medication right away and get that going as fast as possible in order to slow the progression of the disease inside the blood vessel, help you feel a lot better. So as I was saying earlier, you know, we certainly would like to find a cure. And what we do know so far is that there are 3, and I think now we have a 4th pathway, and so we can talk about that maybe this week. There are 3 pathways that have been discovered that they're involved in causing this disease. The first pathway is endothelin pathway. There's too much. And so some of you are on endothelin blockers. Some of you are on nitric oxide medications to raise the levels of low nitric oxide levels. So we're giving you nitric oxide medications. Those are those PDE5 inhibitors to raise the level of nitric oxide. And then the last one is prostacyclin, and that's to as well raise level of prostacyclin. And you know that as the selexipag or the epoprostenol, the Carapul and the Flolan. So we always, you know, try now to get patients on at least 2 therapies within a short period of time. And we are being more aggressive with treatment options. We have risk assessment scales that help our doctors decide, you know, how poorly somebody might do based on, you know, a combination of tests and the walk and how they feel. So, you know, we try to be a bit more aggressive. So, and we can give 3 therapies. So chronic thromboembolic pulmonary hypertension is the only form of pulmonary hypertension where there is a potential curable, you know, treatment, and that is the surgery. So we certainly would look to see if someone has disease that we call resectable, and that means like, is it kind of proximal? Is it close to the heart, far away? We certainly don't make that recommendation. We send a patient to Toronto or Ottawa. Quebec has a surgeon, and they take a look at films, and they may want more films, and they may want updated films. So they take a look at that, and they try to find out whether or not a patient would do well, and are they, you know, a candidate for surgery? Because there's certainly lots of things that a surgeon will look at to make sure the bottom line is, are you going to do well at the end of that surgery, you know, as cause no harm. And so if you can have that surgery, that's ideal. It's frightening for some people, but, you know, there's a lot of education that can go along with, you know, what this surgery is about, what the risk is, you know, recovery time, things like that. But certainly clearing the lungs of those clots is the best. If you're not eligible for surgery, then there is a medication. So that's Adempas or riociguat. You're familiar with that term, that drug, maybe, because you'll also use that in pulmonary arterial hypertension. So lung transplantation as well. It's considered a treatment option. It's not considered a cure. That's because transplantation is yet kind of switching one chronic illness to kind of another, really. Patients who undergo transplantation will not any longer have pulmonary hypertension, but they will be on medication, immunosuppression, to suppress the body from fighting this organ that the body knows it doesn't belong to me. So they suppress the immune system so the body is not constantly trying to fight it. And that just living with immunosuppression over a long period of time certainly takes its toll on the system. And I think it's still 50% 5-year mortality rate. So they really want to make sure that we wait till the very, very last second to give someone a transplant, keep your organ for as long as possible, so that, you buy more time with your own organ. Not everybody's a candidate. There's so many people that just are not for various reasons. If you've had cancer within 5 years, if the BMI has to be, I think it's 31 or 30. I don't quote me on that. I'm not 100% sure anymore. Compliance, you have to, they certainly want to know an awful lot about compliance. Can you move to, Toronto or wherever you want? You have to be near a transplant center. Do you have help? It's very important that you have someone that will be with you and that will help you after there's many things that they sort of go through to decide whether you're eligible. And also at the end of a conversation with any transplant respirologist, you may say at the end of that conversation that I'm not interested, and that's fine too. So usually the first meeting is about what transplantation is and if it's for you or not. And then part 5, we're already at part 5, which are the resources. So clearly PHA Canada has an awful lot of good resources. The main website, Living with Pulmonary Hypertension videos, Living with Pulmonary Hypertension, the PH centers are in there. You have the new to PH kits. Our Pulse newsletter is always well done, and lots of good information, as well as the Connections magazine. There are community supports, and PHA Classroom. Thank you for attending. I will also say that for some of you, there may be support groups that you have in your area. And we have always had a really good one here in Ottawa. It's long lasting. It's luckily for us, we just have had something that works. We have gone through several leaders of the group, and it always just works out that we have great leaders, and that makes a difference. I go to the support groups myself, and if you have an interest in starting one in your own area for more support in your area, feel free to reach out to us, because we would love to help you get one started in your area.